And as I mentioned, it's been a few rounds of Japa from
Yeah.
the 80s to the 90s to the noughties to now.
Hello, healthcare enthusiasts, and welcome back to The Cure. This is the podcast where we're revolutionizing the business of healthcare in Africa, one conversation at a time. I'm your host, Temitope Coker, and in each episode, I sit with the people that are shaping the future of healthcare on the continent, from founders to investors to change makers and beyond. And our goal is very simple: to infuse hope back into the narrative about African healthcare. In every episode, we ask one key question: what does it take to revolutionize the African healthcare business model? All of our insights are powered by TC Health, your trusted source for pharmaceutical and healthcare insights in sub-Saharan Africa. So let's get into today's episode. Today, we are tackling one of the toughest questions in African healthcare. How do we fund it from within? How do we fund it ourselves? And we have seen drastic donor declines that were catalyzed by the US funding cuts earlier in the year. We've seen that external investment from foreign private investors can either be unpredictable or often come with a billion strings attached. But there is a new wave of African investors that are shaping and stepping up, and they are putting their money where their heart is, and they are betting on healthcare on the continent. And I'm absolutely thrilled to be joined by Mrs. Fola Laoye today. She is the co-founder and CEO of Iwosan Investments. She's one of Africa's most respected healthcare investors and has been at the forefront of financing healthcare infrastructure and innovation, from large hospital systems and centers of excellence like Lagoon and Euracare to capacity building and new models of care. Together, we're going to explore why she's still betting on African healthcare and what the biggest needs are and what the future could look like if we unlock the right capital. Mrs. Laoye, welcome to The Cure.
Thank you for having me, Temitope. Wow, that was a real mouthful.
Yes, it was. It was. But I'm so glad you're here because I think this is such an important conversation to have. Everything that we've seen this year can kind of be very doom and gloom in terms of funding, but I do think that there's a lot of momentum, and there are people who are making investment in healthcare their be all and end all. And I do think you are one of those people. And so I'd love to hear, and I think our audience would love to hear the story from your side and the things that you are considering. And as always, before we jump into the very interesting conversation we're going to have today, I wanted to take a couple of minutes to just appropriately set the stage. So Africa is facing significant donor aid reductions. We've seen about 70% decrease since 2021. Obviously, we've seen earlier in the year this kind of large funding cuts from the US. And what this means for the average African is that our governments, our ministries of health, our national HIV, tuberculosis, malaria, and other largely donor-funded programs could lose or have lost significant proportions of their funding. Some of them have lost up to 2/3 of their funding. And that means that people that are seeking these free treatment options are less able to get them. But, and I always like to add the but, it is not all bad news. I spoke about this on the pilot, I personally view this as a wake-up call. We're at this kind of critical point in the road, and what we do now will determine what the future looks like. And I find that to be actually quite exciting, that we have an opportunity to collectively shape our future. But in the backdrop of this somewhat gloomy news, we're also seeing a lot of positive signals. So despite all the donor funding cuts, we're seeing new types of foreign partnerships emerge. And so when I was prepping for this episode, I saw that in September, a new partnership between the UK and Senegal was announced. And this partnership includes a 7.6 billion franc investment in the Pasteur Institute in Dakar. And that is a not-for-profit foundation that's working to advance equitable access to healthcare for Africans by cutting edge science and breakthrough medicine, and they're manufacturing vaccines and diagnostics. And so the purpose of this $7.6 billion franc investment is a 4-year partnership to strengthen Africa's role in advancing global health security. And it's showing this new partnership-based approach to development assistance. We've also seen that 10 out of the top 20 fastest growing economies were in sub-Saharan Africa in 2024. That's half of the fastest growing economies. And among these were countries like Niger, Senegal, Rwanda, Cote d'Ivoire, Burkina Faso, Benin, the Gambia, Ethiopia, Tanzania, and Burundi. And what this means is that we've seen rising incomes, rising business activity that could create demand for better healthcare near home, on the ground, on the continent, which supports long-term investment. So these are all positive signals that point to or attract long-term investments. And specifically in Nigeria, we see a huge growth opportunity. So Nigeria's healthcare demand was projected at $18 billion in 2023, and the private sector was expected to contribute more than 70% of this. And there's also quite a lot of private sector momentum. So according to Salient Advisory, 36% of health startup foreign direct investment in the past year went to Nigeria, Kenya, Ghana, and Uganda. And notable raises include Reliance HMO at $40 million, M Pharma at $35 million, and CarePoint at $10 million, all of which have significant operations here in Nigeria. There's also an opportunity just based on the sheer size of the African population. By 2100, so that's in 75 years, Africa is projected at about 3.8 billion people. That will be around 6 times China's population at that time. Nigeria's population is projected to more than double, so near 480 million people, making it one of the largest countries in the future. And so here is the turning point for the everyday Nigerian. We've seen that through all of these positive signals, even our governments are kind of stepping up and showing that there is progress and momentum. The National Health Insurance Authority Act aims to bring healthcare coverage to up to 83 million people who are poor and who are vulnerable. And we've seen different states moving in this area. So 19 states now run their own health insurance schemes at different stages. And even in Lagos, we've seen that some of the state-funded insurance schemes are outpacing private insurance in terms of growth. And so this just means more families can walk into a clinic with a health ID or insurance ID, as opposed to a wad of cash that they've had to corral from all of their relatives. And so it means hospitals can plan their staff and their equipment because payments are more predictable. It's just so much momentum about being able to have equitable care that is accessible to everyone. And so we all know the gaps in healthcare in terms of number of doctors, the number of nurses, hospital beds, the clinics, affordable, reliable, and safe drugs. The list goes on. But I think the stage is set and Africa is at a crossroads in terms of determining its own future in healthcare. And we have an opportunity to carve a path for ourselves in terms of self-reliance. There is a ton of opportunity, but a ton of risk. And it takes a special type of passion and drive to keep betting on African healthcare. And today, we're going to be talking to one of the people who is still betting on African healthcare. Now, the core question that anchors all of our discussions at The Cure is, what does revolutionizing the African healthcare business model look like? And specifically for today, we'll be asking, what does revolutionizing the African healthcare business model look like when it comes to funding it from within? So, Mrs. Laoye, we're going to start with you as an investor and your journey to where you are today. You trained as an accountant. You started your career at Ernst & Young in Lagos before moving to PwC. over the past 25 years, you've built one of the most distinguished careers in healthcare leadership and investment. First leading Hygieia Group as CEO and later as chairperson, overseeing both Hygieia HMO and Lagoon Hospitals, one of the largest hospital systems in the country. You went on to direct West Africa Investments at the Investment Fund for Health in Africa. You founded Health Markets Africa, and now you lead Iwosan Investments, which is shaping the next chapter of healthcare delivery in Nigeria. Alongside all of that, you sit on several boards, including Old Mutual Life, EchoScan Diagnostics, LifeBank, PAL Pensions, and the Harvard Business School Healthcare Initiative. And you've been recognized globally as a World Economic Forum Young Global Leader. Now, that is a mouthful in terms of all of the experience that you've built over the years of your career. And I think we first want to start with you and understand your journey from accounting all the way to private health insurance, to hospital operations, and now to investment. If you could just walk us through that journey, and specifically, what did you see on the operational side in health insurance, in hospitals, in accounting that has shaped your investment thesis today?
Okay. Well, thank you. Again, thank you for having me.
Of course.
I mean, it was very interesting listening to you because it's always a good time of reflection to put it all together in the way you did. I think maybe one thing I would add, perhaps before I go into my journey, is the fact that, as you mentioned, a good 70% of the healthcare sort of spend and market in Nigeria, particularly, is actually in the hands of the people. So we may call it the private sector, but it's really out-of-pocket spend of everyday people. And that perhaps shows us a little bit of the resilience that our system actually has. Because yes, whilst, of course, government spending has been critical, especially to the more bottom of the pyramid population, which is not insignificant, and so has the donor money. But really and truly, what has really kept and what still keeps the system going is the spend of everyday Nigerians who are looking to purchase healthcare. And I think maybe that's what really got me started on my journey. I'll have to dial back a bit to say, well, it's also a journey that was a family one. So my parents were both doctors. My father was a surgeon, my mother a physician. And they together as a team, they always worked as a team, first and foremost in the public system. So they started out in University College Ibadan and then moved to the Lagos University Teaching Hospital in Lagos, LUTH, and were actually part of the founding team there. And whilst there, they focus very much in the two areas. One, on the teaching side of the medical school and really grooming and growing more doctors and healthcare professionals, but also, of course, on the delivery side through the teaching hospital. They both became very senior. My father was chief medical director of the teaching hospital and dean of the medical school. But at a point in time, the public system was no longer really sustaining, if I can put it that way, their own level of expertise. And that was the first level of Japa, if I can call it that, which was, I would say, in the very late 70s, early 80s, 1980s, around that time, where quite a few of them were no longer being supported in terms of research and all the work that was happening. And most people chose to leave the country. They chose to stay because it was important to them that there was a community of medical professionals who could still look after the communities who needed care here in the country. And I was growing up around that time, around them. I was at Queen's College, then moved on. But somehow, even though I was growing up around them at that time, still didn't feel the call to go to medical school, I must say. So went off and did accountancy, as you said, in University of Lagos, and went abroad and so on. Started a career in financial services and ended up at Harvard Business School to do my MBA. But by the time I was going to Harvard Business School, I think I had come to the realization that indeed there needed to be a more structured way of delivering healthcare to the teeming population who were putting their hands in their pocket to really, try to access care. Unfortunately, around that time, the public system, as I mentioned, was really, really, just not sustaining the kind of care, was losing staff, losing specialists and so on. So not unlike what's happening today.
Yeah.
But this was, like, I would say, the first wave. But still, even though we saw that happen, it was clear that the private sector therefore had a role. Because, as I said, people were still willing to pay for care. And so, those who could give care could do so in a private setting, which could ultimately be more sustainable. And my parents had started that journey by founding Lagoon Hospital. So they founded the first hospital in Apapa. And at that time, I went off to business school. But very much with the mindset of what could I bring back that could really be, if not a game changer, but at least something significant that could help to build, what I could see as a future health system. So I did two things. I really I understood the US system, which I thought was most comparable to what we were doing as a private health system.
Yeah.
And doing that became very much my foray and study into health insurance and HMOs, because the US, of course, was the biggest market of HMOs. Around that time as well, legislation was changing in Nigeria. The National Health Insurance Scheme Act had just been signed in 1999. So there was many different things coming together, which made it fairly, exciting. So I came back already with that sort of experience and knowledge. Actually brought a US-based HMO back as a technical partner to help us think about how do we really set up operations for health insurance. And similarly, I knew the other big sort of area to tackle was capital and access to capital. My parents had done fairly well in creating a corporate entity, which was called Hygeia, which actually was a company that owned the hospital, and where they had brought in individual shareholders, corporate shareholders, all of them local, and therefore had built a governance system, or a system that was well governed, if I can put it that way, with shareholders and a board and so on. And so with that sort of platform, it wasn't difficult to talk to investors, because already there was something that they asked, do you have a business plan? Here it is. Do you have a board? Here it is. Do you have board meetings? Here are the minutes from the year dot, and so on. And those were the types of things that made investors more comfortable to say, okay, we could look at this. And so particularly, I worked quite hard in talking to foreign investors at the time. The IFC, part of the World Bank, became one of our first foreign investors. And from there, we went on to private equity and so on. So raising and amassing capital was a very important part of the story.
Yeah.
I always like to say, just around the time I then took over from my father as CEO, I remember sitting down with some of our key specialists to say, what's the biggest need? And they said, diagnostics. We need a CT and an MRI. This was like 2004, 2005. And believe it or not, there was not a single hospital in Nigeria except the National Hospital in Abuja that had a CT and an MRI.
Wow.
So I said, okay, I'll get it for you, literally. And so, set about really making the business case for the equipment, talking to investors, talking to banks, and raising the capital. It may seem a bit strange, that's 20 years ago, but really, this was a big deal at that time. It was going to cost us something like $2 million, and it was going to be a lot of money. But anyway, we managed to, find the right, group of financiers, and we funded it. And it was a game changer, bringing those two pieces of equipment in, because it changed the face of diagnostics. just as radiology had done worldwide, imaging particularly has really deepened the understanding of disease in the body. And obviously that had helped in terms of opening up access to treatment. So that was a significant game changer. It also meant that we had to do some work training doctors to even refer and ask for, a CT to be done as part of the diagnostic story that they were trying to unpack of their patients. So a few things like that came up along the way that we realized that to do this well, yes, you needed the capital. Yes, you needed the infrastructure, but you needed many other things. You obviously needed to help to build skills. You needed change management, to help to really change and advance the way, healthcare was being managed or run. And of course, we also needed to be able to bring it all together in a way that we could put it in a risk pool.
Yeah.
And really create, what would be the disease coverage, what would the costs be, how would a health insurance scheme be able to wrap its head around this growing sort of industry. And of course, along all of that, the diseases themselves were evolving.
Yeah.
So one of the big diseases that was on the table when I came back was HIV/AIDS. And again, not unlike what we went through with COVID. At that time, it was like, what do we do with
epidemic
this? It
kind
was
of levels.
almost an epidemic. It was threatening to be one, and one where in Africa, particularly in other parts of Africa, it had really taken the lives of what I'll call the next generation, of the young population. And that was a real concern, especially when you think about the economic fabric of a country. You need the young population who will be at work. And Nigeria being the biggest country in Africa, there was a lot of concern about what would happen if HIV really became an epidemic here. So I was jumping into a sector that was already underfunded, very fragmented, and yet having to deal with, a big disease burden.
Yeah.
So those were the things that I would say I started with, but they've all continued till now. There are all still issues we face, whether it is the jackpot of people, whether it is the capital, whether it is the disease burden, all those things are still very much present now.
Yeah, yeah. I love that because I took two things away from what you said. In the beginning, when you said close to 70% of the spend in Nigeria is actually out of pocket.
Yeah.
It's actually it's in the hands of the people. And I just got this image of a lot of people. Yes, we say the healthcare system in the country, on the continent, is underfunded, etc. But we also don't kind of acknowledge that the healthcare sector is being upheld primarily by the spend of the average Nigerian.
Yeah.
And I think that's a very important nuance to keep in your mind, especially as you think about investing in healthcare in the continent. I also love how you mentioned, you saw all these changes happening. You first started in financial services. You didn't get the call to healthcare, even though both your parents were practitioners. But you saw the different things that were happening. You saw the first wave of JACPA. You saw new policies, etc. And so as you were going in to get your MBA, coming back and responding to the things that you saw was like, that was your response to what you saw in the landscape. And this has been a trend with a lot of the guests that we've had on the podcast, in terms of they saw a challenge, like Yao saw the Jackpot challenge as well. And he said, what is my response to brain drain? I'm going to found my own company so that scientists can practice science on the continent. Or Dr. Nato, he writes a lot about the health tech space. He saw that there was a gap in anyone chronicling health tech. And so he filled that gap. And so for you, you saw these policies, you saw these trends, you saw these things happening. And your response was to bring back what you learned in the US
as well
into
as
healthcare.
capital.
Yes. Yes.
So I think capital has always been the biggest story, or maybe the real link in my career. And but it's been interesting that whilst, yes, access to capital and really putting capital together has been a key part of the story, it has still kept me very close to what I'll call the management and operations. So unlike perhaps a pure private equity investor who just hands the capital over and sort of, sits and waits for every quarter's reports and so on. In my case, maybe because I was amassing capital from within a company, which at that time was Hygeia, it also meant I was, I guess, accountable to how were we spending the capital, what were we spending it, what were the areas of investment that we either needed or that we were actually investing in, and how did we make sure that that investment was going to create the impact that we were expecting. The impact we were really expecting was how would we increase our capacity to look after Nigerians across different disease, modalities. So that was one key sort of part that I had to sort of keep making sure we were achieving. And then, of course, how did we make sure that we were really achieving the double bottom line, which was also a financial return. And I guess that's the people often say that's the big difference between the public and the private sector. Although I argue differently that the public sector also has to make sure there is a return on investment. It's just that it's not going back to, I would say, individual shareholders or corporate shareholders. It goes back to the,
back into the system.
But, that's what keeps the system going round. So for me, I was bringing my accounting and business mindset of capital allocation, but also to the management and to the operational side to say, how is this making a difference at what I like to call the sharp end of care? How were we making sure that, yes, indeed we were. And that took us, I think that journey particularly was very interesting with health insurance. Because with health insurance, you could make that link a lot easier. You could say, okay, you had to understand the unit economics of every case. And so understanding the unit economics then helped to say, okay, this is the cost of care, or this is the cost of looking after an individual or a family for a year. And based on that cost of care, this is how you could put them into a bigger sort of a risk pool. And, therefore cover, leverage, let me put it that way. A risk pool is really just leveraging, right? Whatever funds have come in to be able to say, okay, how can we then look after a much bigger population? And so, and in doing that, you could also then link that all the way back to the care itself, when people are then sitting in front of a doctor, or, what's the cost of a blood test or an x-ray, and ensuring that those systems continue to be funded. In government, they tend to call them revolving funds, revolving drug fund or revolving this fund, but really doing it not just as one single area, but, doing it as a pool of care, that is funded on a revolving basis. And that was very interesting. I think the time I spent in health insurance, I found was pretty fascinating. Maybe, well, I'm not an actuarist by any means, but yes, it did make me use my, my mathematical thinking to say, okay, how do we really think about care, but from the mathematical end? So I think that has also kept me, very much, and I think you said it right when you said, what keeps me in the space is because I see the cost of care, I see the numbers, but I also see how those numbers translate into people being looked after. So I see the very direct link. And I think that's what, for me keeps me going. I mean, when we started health insurance, We then went on not just to do a corporate health insurance scheme and as well as a national health insurance scheme. We also did a community health insurance scheme. But the community scheme, of course, was for populations who really couldn't afford it.
Yeah.
And so again, it meant raising a different type of capital, which is more closer to the donor capital, to come in to subsidize care. And we did that successfully for about 10 years, and we looked after almost 1 million people.
Wow.
But what was really special about that was that, yes, we knew the donor funding, which like now is never there forever, right? But what did we learn? What did we create? What was transformative about the program? That was what we kept thinking about and making sure we were also pursuing. So a few things happened. One was creating the legislation around what is now called state-supported health insurance.
Oh,
So for
interesting.
states to actually think through, how do we actually put schemes together? How do we take it and create our own laws?
So those schemes that I was referencing at the beginning.
So those schemes, so the Quara scheme was the first lot of legislation in country was the Quara actually House of Assembly.
Okay.
They first put their own legislation together for health insurance. And that's then got replicated now in the states, the 19 states
Nice.
who have created their own
Yeah.
laws. So that was one. Then the other was, what is the operational mechanism for those schemes to be able to, again, be sustained and sustainable? And that led to health insurance management systems,
Yeah.
state by state. So in the public sector now, most states have their own health insurance management agency.
Okay.
In Lagos, it's called LASHMA.
Yeah.
But if you go to most states, they have that. So those two things came out of the work done in that
Wow.
program. It also taught me that it was important to advocate.
Yeah.
So our partner in that program was Farm Access. And so Farm Access became a real convener and advocate and could take this on the road
Yeah.
more than even we could. And that's how they were able to sit with other states and other state governments in putting this together. So again, it showed me that everything you do, there's potential
Yeah.
to really do something that, creates a sustainable role model. So therefore, when you're doing what you're doing, be intentional
Yeah.
about it, because it takes a while. It's taken almost 20 years to even talk about health insurance and that journey.
Yeah.
But certainly it's happening.
Yeah. And, even as you were talking about this, because I think we've had a conversation about these community health schemes that you've done in the past. And there was a particular scheme where the sheer demand for the program that you were running surprised even you and all of the organizers. And I think another point that is so important as we think about investing in healthcare in Nigeria or on the continent is that there is a lot of demand for healthcare. I think people assume that, okay, if you set up all of these programs, who's going to come, but I think the people are, they need healthcare.
In dire need.
In very, very dire need. And I think in every other sector, when you see that kind of demand, it's a huge, attractor for investment.
Right.
And I think that should also be the case for healthcare investments.
Indeed, it should be. And in some ways it is, but not in all the ways, because health is a social good. Some people like to even call it a public good, but I'll even say social good, and which means that if you then think about it in that sort of, in all its ramifications of demand, then you're not necessarily able to capture what I'll call effective demand, which is the demand which can pay.
Yeah.
And in the end, it's the effective demand that makes the financial, investment case. And so, you have to then sort of think about it. And that's why I mentioned what I did about the community schemes, that the type of funding that was required was donor funding.
Yeah.
Because it was not easy. It's still not easy to make a financial business case for looking after a population who have very little money to be able to, or have very little spend to be able to pay for the care. However, even as we then look to the markets where there is more effective demand and so on, we still have to be intentional about how we do that in a way whereby, again, insurance would be one of the key ways where you can really leverage.
Yeah.
So the haves to the have-nots, by really create real equity
Yeah.
in the schemes. And I think that's something, well, we haven't gotten there yet because we still need to ramp up, even those who have. But certainly I would like to think that would be a key game changer when we have big enough risk pools
Yeah.
where we can then create more equity and more access.
Yeah. So it's basically like a tiered, where like the people who can afford to pay for health insurance, healthcare, etc., the funds that you derive from that,
Yeah.
as you grow the risk pool, obviously, the funds you derive from that can be diverted to also provide care for the people who might not have as high willingness to pay or the means to pay.
Yeah, but I wouldn't say diverted. I think it's just the fact that everybody brings their own funding to the pool.
Okay.
Right. And in fact, what we're seeing now more and more with things like the Basic Health Provision Fund of the government is that now it's been legislated that even government puts its own funding in the pool.
Into the pool.
So that's the whole point of a pool. The fact that everybody can come in there with, with hands and put what they have into it. And that gets leveraged. And that's what then
That,
can
creates that
create
equity.
the equity and creates better access for all.
Yeah.
So that, I guess, that is the holy grail, right? Universal health coverage. But we'll get there.
Yeah.
But I think in the interim, for those of us as investors, so I mean, obviously, I lived that first round. I always call it my 1.0 round of being as part of, obviously the family investment vehicle, and management vehicle being Hygieia, building lagoon hospitals, building Hygieia HMO from the ground up.
Yeah.
And that was a very exciting time. I mean, yes, I was fortunate, because I was a business family. Both my parents obviously had done a lot before I even came on the scene, but it was also extremely challenging.
Yeah.
Because in some ways we were pioneering, pioneering really being able to bring up quality healthcare, and at the same time being able to really create the demand side, through insurance. So it was quite challenging, but at the same time, it was rewarding because we saw the growth, in what was happening, and obviously the care that was being given to the population. But, I fast forward from there, and that's what then brought me through the various journeys you mentioned of doing some work on the private equity side, doing some work in consulting, and then finally co-founding Iwosan, which was, again, not unlike what had first been the beginning of Hygieia, which was to bring together a group of like-minded local investors who were really ready to invest for the long term and to be, to put in patient capital to build, the healthcare ecosystem. I guess COVID was also a landmark time in all our lives, and particularly in the Nigerian health sector, and particularly for the Nigerian population, those who ordinarily would have been able to go abroad for their care, and we know medical tourism is significant, just realized they couldn't go anywhere. Borders were closed, planes were not flying, everybody was grounded. And of course, there was almost a mortal fear. If anything happens to me now, where do I go? And I think, yes, that has helped awaken the sense of we've got to be able to do this for ourselves, by ourselves. And so being able to bring local investors together was, a seminal moment to be able to say, okay, how do we do this for ourselves? And with the Iwosan platform, Yes, we started by acquiring Lagoon.
Mm-hmm.
So again, knowing that there was a system that had been created with governance in place,
Mm-hmm.
with quality. Lagoon was Joint Commission International JCI accredited, and with several specialties already baked in. So it was a good place to start with 600 staff, and so on. But knowing that our own footprint as Iwosan would be a much bigger one.
Yeah.
But knowing that acquisitions was going to be a key part of our growth, and that being the case because one thing about the private health sector is also the fragmentation.
Yeah.
It is an extremely fragmented system, and we felt that there needs to be consolidation. There needs to be ways of how we can bring the capacity, the expertise that is on ground, which is not a lot, given the Jackpot syndrome.
Yeah.
How do we bring it to work together?
Mm-hmm.
Again, for the good of the patients, for the good of the people who really need the care.
Yeah. And so I actually, this brings me to one of the key questions that I have for you, because hearing you talk about all of the different ways you have contributed to investing in the healthcare sector, we've seen global funds and foreign development assistance kind of hesitate or even stop this year in terms of money coming in. I'm curious, why is Nigerian healthcare still a rational bet for you in terms of institutional capital? Like, why do you believe it's still worth the risk to kind of inject capital into the Nigerian healthcare system or into the African healthcare system? Because you sit in the seat of an institutional investor, I would love to hear what is that risk-adjusted story that you see for healthcare here?
I think it's the story would be the story for most industries, in the sense that we are in a heavily populated country.
Yeah.
Yeah. And one that continues to grow in terms of its population. And therefore, that's a market.
Yeah.
It's a market you can't ignore, for anything. And especially for health, because health is something everybody needs.
Yeah.
So again, going back to where we started from about the fact that health is a social good, yes, but it's actually, it's so, pivotal, in terms of in any country's development.
Yeah.
And so from that perspective, we keep tracking, and the higher obviously the bigger the population and the better the economic growth in any country, I think you'll see it globally that the healthcare spend tracks that.
Okay.
So the healthcare spend always tracks GDP in any country. So the bigger, and GDP is a function of two things, right? It's a function of population and also wealth.
Yeah.
So if either or both go up,
Yeah.
then certainly the healthcare spend is going to go up. So that's one thing we watch.
Yeah.
So as you rightly said, if you think about, the Africa being this 3.8 billion people market, Nigeria being almost 500 million people. And again, if you even sit down and look at the McKinsey reports and any of the other reports and gives you, or even the World Bank reports that are tracking where indeed economic growth, how it will inch up and happen, then the numbers are still relatively interesting.
Yeah.
The $18 billion market you've talked about health today is about double what the market was when I started here in my career. So, and of course, we see the opportunity to grow. Now, again, as you said, how do you adjust for the risk? Because the risk is all the things we've seen over the last 10, 15 years. The economy not growing as quickly, as much as one would have thought. The people leaving the country because of it, the talent leaving the country. And then, of course, even the challenge that you see around, just the fact that you're not able to, really propel, the services, as quickly as one, expects it to be propelled. So, and of course, the devaluation of the currency being a significant issue. and the fact that we are still extremely import dependent. So there are many, many things, many risks. I think I'm just trying to list what we all know the risks are. But indeed, what keeps us going, as I've said, is yes, there's a big market, there's a growing market. And of course, you also look to some extent what the macro, what the policy environment looks like.
Yeah.
We have a policy environment now, and which has been the case over the last 2-3 years since we started investing, of, let's hit the ground.
Yeah.
Let's deal with the issues. So we've dealt with the FX issue. We've dealt with the fuel subsidy issue. So, we're dealing with taxes. So let's deal with the things that really will make sure that we have, an economy and an economic base that will be the right platform for the future. And we see that. And I think a lot of investors see that now, not just in health, but across different disciplines. And seeing that, and as I said before, knowing that whether we like it or not, we've got to put a healthcare system in place on the ground in country. Those two things together, I think, in a way, outweigh the risk.
Yeah. And you mentioned policy, but before we go to policy, I think telling the story of the risk adjusted story and going through the risk, because we have to be, at The Cure, we want to focus on the hope that we see, but we can't ignore the realities and the challenges. And I think building healthcare in Nigeria is incredibly rewarding, but equally demanding and challenging. And so I'd love to hear what keeps you going on those tough days when you're facing this long list of risks that you just mentioned. Like, what is it that keeps you going in those
One
days?
of my team members calls it when we have to deal with force majeure on a Tuesday and get to the end of the week. That's the way we see things.
I love that.
But indeed, what keeps me going? It's really people. It's the people we look after. The fact that, like I said, it's numbers sometimes because I'm the accountant, I'm not the doctor, but the numbers always tell the story of how many people have we looked after, what's sort of diagnosis. Again, because we are very much quality driven. So we don't just look at the financial numbers, we look at the clinical numbers as well, the clinical indicators. And just looking at that always makes me feel indeed, we're looking after X number of, even down to the level of number of, those who have hypertension, or those who are diabetic. And, how many of them in that space, in this period, have we really helped to optimize their care or their living, in a way, because you also want to, and that's why I'll just segue a bit to say we're also invested in wellness, because we know how important it is to also keep people well, and not have to get to the point when they are really, really, about to fall apart. So I think that's what keeps me going, being able to see that indeed everything we do every month, every quarter, every year is actually, down the road leading to better care. And of course, we see how many babies are born. and that always gives us a lot of joy. But in addition to that, I think also, it's also the level in which we can work on creating more skills. Because this is a key issue now. The JACPA has really created a significant skills gap. And as I mentioned, it's been a few rounds of JACPA from the 80s to the 90s to the noughties to now. When I went to Unilag studying accountancy, I would say that maybe 80% of my classmates who were in medical school left the country.
Wow.
So we have lost a significant number of doctors, especially. I know different sectors have lost a significant number of their own talent as well, but I think for whatever the reason is, the medical talent have been hit the most. And I won't say whatever the reason is. It's also been obviously just not being able to give them a standard of living. Pay them right and make sure that they can give their children a standard of living that is, world class.
Yeah.
And not being able to do that in country has led to this real, exodus. And so we feel very much that for those who are still here, we also feel extremely committed to really improving their standard of living, improving their skill set,
Yeah.
improving their learning and what they can do to, again, ensure that we're looking after people as best as we can.
Yeah. And, when you were giving the numbers, even when you were in Unilag, the number of your colleagues who went to medical school that have left, I think when we were researching for this episode, combined between the UK, Germany, the US, and I think Canada, it's about 17,000 Nigerian doctors that are practicing outside of the country. And we have about over 80,000 doctors registered in the country, like officially. That means almost a quarter of the doctors are practicing abroad. And I think it's really important, as you say, in your investment philosophy, your operational philosophy, that to try to create the environment here that can keep those doctors and nurses and healthcare professionals here. But you mentioned policy. And I think there's been some recent policy shifts. And one of the policy shifts is this dialysis subsidy that we've seen. So His Excellency President Tinubu and his administration recently introduced a subsidy for kidney dialysis in August of this year. And this new federal subsidy cuts a session from about 50,000 naira to as low as 12,000 naira in your major federal hospitals. And when you're on dialysis, on average, you do a session weekly or every other week, which means that the monthly cost for dialysis pre-subsidy was close to 100,000, if not exceeding 100,000 naira, which in a country where the minimum wage is around 70,000 naira, this is a catastrophic cost that could potentially force families and patients into poverty as a result of the cost of this care, or could cause them to avoid this care in general. And I think some of the studies recently highlighted that only 2% of patients with end-stage kidney disease in Nigeria actually receive dialysis, and 80% are unable to even sustain dialysis for more than 3 months because of the cost. And we know that there are about 80 functioning dialysis centers in Nigeria, but we have over 25 million Nigerians estimated to suffer from chronic kidney disease. And similar to you, I always compare to the US system because earlier in my career, I did a lot of work in US healthcare. The US has over 7,000 dialysis centers in the country. And so to me, I look at this as such a huge opportunity for infrastructure investment to bridge that gap. And not necessarily specific to Iwosan, but just in general, anyone who is thinking about investing in healthcare infrastructure, I'm curious to hear your thoughts on what is the investable path here as we think of the rise of chronic disease and how institutional investors can step in to bridge the gap in care.
I mean, I will speak to our story at Iwosan, and that's why we are very intentional with our strategy. And our strategy is one that actually speaks to creating the infrastructure, the talent, and the system that will look after such diseases. When I say such, I'm saying, yes, we're talking about renal disease, kidney failure, but we are also dealing with cardiac disease, we're dealing with cancers, because these are the rising epidemics.
Yeah.
So just like as I mentioned that 25 years ago when I started my career in health, we were dealing with HIV and malaria and TB. Now we're dealing with, as I said, it's cancer, it's cardiac care, it's renal disease. And so, the pendulum has swung so much from what could be handled in the primary care setting with fewer dollars or fewer naira to what now needs to be in place,
like specialized
and
care.
Very specialized care. We need quite a bit in terms of equipment now. We need real very, very top of the line diagnostic tools. we need highly trained specialists. Highly, in fact, I like to see the specialists themselves as infrastructure now because they cost as much as the infrastructure, and so on. But that's really where we have to think. And I am pleasantly surprised to see the government and the president thinking along these lines. So, in addition to crashing the cost of dialysis care, there's also been now a cancer fund, a catastrophic health fund, which the government through the NHIA is also administering to bring down, and support the care of cancer. We're also now beginning to have that discussion around how can we also fund, how can public funding also come into cardiac disease in a very big way. So I think the government is doing what it should be doing.
Yeah.
I think the private sector is also doing what it should be doing. But no question, in all of this, we need the infrastructure.
Yeah.
So one is we're talking about putting money in on the demand side and subsidizing. That's one. But then there's the investing and building the infrastructure itself.
Yeah.
So the federal government through the NSIA, the Nigerian Sovereign Wealth
Investment Authority,
is also building cancer centers and cardiac centers and diagnostic centers around the country. I think they're doing 25 because we just have to do them. We can't do one or two. No, not for 200 million people. The disease prevalence, the incidence, the costs of care are just so high that we have to democratize it and put it everywhere. And it's the same thing in the private sector. We just have to get out there and roll out the infrastructure too.
Yeah. Yeah. To me, I see this as a call to action. Anybody who's listening, that the call to put your money where your heart is, we could have 7,000 dialysis centers in Nigeria easily. So yeah, just plugging that a little bit.
Yes, please.
Yes.
Every naira counts.
Every single naira counts. But I want to talk about a specific investment that Iwosan has made. Also, a quick fun fact. Iwosan is the Yoruba word for cure.
Iwosan.
Iwosan. My Yoruba is being correct.
Is to cure, to heal, to look after.
Yes.
So it's, Ile Iwosan in Yoruba is a hospital, a nursing home. It's just that whole, place where your health is being cared for.
Yes. I like that. Iwosan.
And the reason why we chose it is a Yoruba word, but it was because we wanted to be proudly Nigerian.
Yeah.
We believe, we are only 4 years old, but we believe that we will go, global at some point.
Yes.
And we wanted to be able to take a global name out there.
Yeah.
To show exactly what we're doing.
I love that. One of the investments you've made recently, in December of 2024, actually, almost a year ago, was the Lagos Medipark, which was a very exciting announcement, a private-public partnership between Iwosan, IASO Medipark, and in partnership with the Lagos State Government. And it is a 140-bed multi-specialist hospital with state-of-the-art diagnostic center, residential accommodations for healthcare professionals, and training facilities to develop a skilled healthcare workforce. So to the point, you're putting your naira where your heart is in terms of training and building capacity. It also has commercial and retail spaces dedicated to medical services. And at the kind of groundbreaking ceremony, you made a few statements that I absolutely love. You said that to the people of Lagos and Nigeria at large, this is for you. It is a pledge to your health, your future, and the enduring promise of progress. Let us proceed with determination, knowing that what we start today will serve generations to come. Together, we are transforming healthcare one groundbreaking initiative at a time. And I think this ties...
Wow, I said that?
You said that. You did. I loved it. And it aligns perfectly with our season 1 theme of By Africa, for Africa. And I'm just dying to hear all about the process behind this investment. What was the inception? What was the idea behind the investment? I also think the model is very interesting. So one thing I found really fascinating was the mixed use nature of the Medipark. So combining a hospital with residential, commercial, and retail spaces, from an investment and sustainability point of view, I'm sure that integration makes a project more attractive. So, just dying to hear
we
your
need
thoughts
another
on
whole
this.
podcast for this, but I'll do what I can in a few minutes.
Mm-hmm.
And to give the kudos to the Lagos State government and the
Yes.
current governor, Mr. Babajide Sanwo-Olu,
Mm-hmm.
because really, it came from them. In
Mm-hmm.
2020, they put out a request for proposals, an RFP,
Mm-hmm.
asking for private sector consortia
Mm-hmm.
to bid. And they had already scoped what they expected to see. So this is a site which was an old nursing school. It
Okay.
used to be the main nursing school for the whole city
Mm-hmm.
and nurses accommodation.
Mm-hmm.
And, it was a very well-known site, which unfortunately became derelict because I think the nursing schools got moved out,
Yeah.
into other parts of the city. And so, they put it out there. It's not the first time. I think they tried a few times. A few different governments had also tried to say, what do we do with the site? But as I said, they'd been very thoughtful in saying, okay, this is a fairly large piece of land.
Yeah.
How do we maximize its use?
Yeah.
How do we first stay true to it being a medical site? And then make sure that we can create a sustainable model around it. So that was the way in which they actually put the tender out. So they made all of us think before we bid. We had to think according to what they wanted to see, which was this mixed use development.
Okay.
But what was also interesting was that they said, come as a consortium, come with your financiers, your architects, your builders, your contractors, your management team, everybody come together, because we want to assess a whole team that we know can deliver. So that was also interesting. I guess maybe they had learned, from the various rounds in the past that everybody needed to be at the table.
Yeah.
So we started this process. 2020 was a process where about 30 of us bid, 30 consortia. We got, looked at, and they, ended up with 12. And then we went through a very competitive process, down to 6, down to 2, and then we ourselves won the bid. So that was a very interesting process in itself. And even building the consortium, you collaborating with those who were not even necessarily had done healthcare before, but saying, let's come together and put a project like this together. So that's been pretty interesting. And then, of course, still thinking through from the government's point of view. Government wants to ensure that, yes, there is training. They want to make sure that the communities are being looked after and so on. So, infusing all of that in what we also felt would be a bankable, project. But I think what has been quite exciting as well is the way in which Nigerian doctors in the diaspora and allied professionals have been so keen on something like this, because I think everyone feels they need a way in to the system.
Yeah.
And the fact that we're not just putting the infrastructure of the hospital together, but there is real estate, there's accommodation, and there's even office space where they can come in and out and practice and still know that there's a hospital on their doorstep.
Yeah.
There's a place they can live. I think just creating that ecosystem has made it quite exciting as a potential way of their own re-entry into the country. So I think that that's what would be a big game changer.
Yeah.
If we could really, and we are at the moment, we have a significant database of Nigerian diaspora doctors who are very keen on this project.
Yeah.
But that I think if we did this and it happens, and it paves the way.
Yeah.
I mean, look at India. Hospitals like Apollo and Fortis did something exactly like this. The first couple of Apollo hospitals were on government land, as PPPs with certain amount of public patients being looked after. But it meant that they could do projects at scale, right? Rather than a small hospital, they could do bigger things, which is what we are doing now. And in doing so, they were able to really attract Indian doctors from all over the world to come back. And the rest is now history.
Yeah.
So we believe that, this is our time, this is the country's time, and it's the right time. And indeed, bringing the capital together for a project like this has been pretty significant, but we can see the way forward.
Yeah, I love that, because we just had the discussion about the brain drain and the waves of Japa, and this is like a response, both from the public sector, with the Lagos state government, and the private sector, to not just, Nigerians, everybody loves to complain about Japa, everybody's leaving, but What's your response to that? And this is a very direct response. So we're going to just conclude the discussion today. And I would love to understand your future outlook for healthcare. Specifically, if you had $1 billion in capital tomorrow, where would you put it? You're an institutional investor. You invest in infrastructure, not necessarily in like the seemingly sexier health tech space that everybody is kind of jumping on. But I would love to hear from your institutional lens, if you could direct $1 billion tomorrow, where would you invest it?
I mean, it will continue to be infrastructure because there's just so little of it, of what is the infrastructure of tomorrow.
Yeah.
Right. So that's that's just,
That's a
it's a
no-brainer.
no-brainer. It will be definitely on training and building the capacity for training. I love the fact that this government with the Renewed Hope agenda has really been focused very much on building medical training.
Yeah.
I mean, already 3 new medical schools are being built, a few universities of medical education. We need more.
Yeah.
And whatever the private sector can do or private money can do to really facilitate and support that, I think is another huge initiative.
Yeah.
I mean, I like to go back again to my parents, right? Because they were there right from the beginning. I remember my father talking to me about building 35 medical schools around the country, and they just went from having 2
Yeah.
to 35 in a number of years because they just had to.
Yeah.
And I think that's where we are again, where we've just got to rebuild, the medical training system. So that's a big one. And then, of course, I mean, even as I talk infrastructure and tech, I almost don't even see them separately. So tech and medical tech is a key part of the infrastructure that we need to have, because the infrastructure of tomorrow comes tech enabled.
Yeah.
So I can't build a hospital of tomorrow without it being totally tech enabled.
Yeah.
Even today's work, we are cloud first in terms of technology. So of course there's all that cost as well of data centers and so on that are required to just keep the data,
Yeah.
of the healthcare data, and keep it safe. Of course, we are also having to think through how do we make sure that the machines we use are also tech enabled.
Yeah.
Now there's AI that's even helping to speed up the way in which the machines work, and so on. So I almost don't see tech as separately as perhaps most people do.
Yeah.
I see it very much as part. But maybe therefore my own third area will be the supply chain. We are in dire need of an adequate medical supply chain.
Yeah.
So, manufacturing of drugs, manufacturing of consumables, manufacturing of any kind of material that we're using in the healthcare space, even equipment.
Yeah.
The fact that we're importing everything is such a cost sink. And again, I use the India example. One of the key things India did was they really attracted, the big OEMs and so on to come and set up factories.
Yeah.
So now you want to get a CT scan, it's made in India. You want to get an X-ray, it's made in India. Everything is made in India and in other markets like that. So we need to get there.
Yeah.
And I think that's so I would look at those 3 buckets: infrastructure, training, and supply chain.
I love that. And I love your answer about infrastructure versus tech, because a lot of pessimists always make the argument that how can we invest in tech? We first need to invest in infrastructure, then we can invest in tech. But in the millennia that we're in, it's all kind of integrated. So I like that you think about it together. So we've covered a lot today. As always, whenever I speak to you, it's always such an insightful discussion. I have so many ideas. So you might see some TC Health articles come
I would love
just from
to.
this conversation. But I want to conclude. We always wrap up with rapid fire questions. So we'll ask a few questions, and we just need a simple 1 or 2 sentence answer from you for each of the questions. The first question: what's the biggest deal you've ever closed?
The Medipark.
The
Without a
Medipark.
doubt, yes.
Amazing.
I mean, it's huge infrastructure, huge costs. I don't want to tell you how much.
We'll keep that a secret.
Yes, we will for now.
Okay, but that's good. What the next rapid fire question: what's one myth about healthcare investing in Africa that you wish would just disappear, go away?
I think the fact that it's never profitable, that it will never create a return, that it's seen so much as a public good. I think that's a myth, because indeed, it's a business like any other. It certainly needs to be efficiently run. It needs to get, its unit economics right. It needs to sort of make sure the demand is there. But once you do those things, it is profitable.
Yeah.
And therefore investable.
Yeah. The next one, what is a business principle from outside of healthcare that you think more hospital or healthcare operators should adopt?
I think it's two. If I
Okay,
could.
yes, you can say two.
So one is customer experience. I don't think we think about that enough in the healthcare setting, worldwide, and definitely in Nigeria. You see customer experience in so many other sectors. You see it now in banking, you see it in retail, you even see it in, the way fashion is sold and so on.
Yeah.
But we don't think about that here. We tend to think more about the clinical experience.
Yeah.
But there is a customer experience that needs to also be really handled. I think the other thing is really just lean efficiency.
Yeah.
There are these Toyota principles, Kaizen. Now Kaizen is becoming more popular in healthcare, but I think it needs to be more so here, where we really think, how can we create more efficiencies in how we do things?
Yeah. My second to last rapid fire, what's a book or article that you would recommend to a young African healthcare professional or entrepreneur right now?
If it's on healthcare, I would definitely talk about the IFC Red Report, the business of health in Africa. That was a fun report. I did a lot of work on at the time with the team putting it together.
Plug.
But it was with McKinsey, and it was the first time we created what looked like the investment case for healthcare, in Africa. So it's a good book to read. But outside of health, honestly, it may sound a bit pat, but there's a book that I took my team through last year, and it is Stephen Covey's 7 Habits. And it has been a fantastic book, 7 Habits and Leadership Principles. And it's a book that, I know it by heart almost, and I use it almost on a daily basis in terms of thinking, start with the end in mind. And some of those things, especially as entrepreneurs, really resonate. So it's a good book.
Nice. So some homework for our listeners. And my last question, which I always ask all of our guests, what gives you the most hope right now?
I think it's a few different things coming together. The macro looking brighter. Definitely government being much more focused and intentional about healthcare and how they invest in healthcare and what they do. The fact, again, that government is more ready to work with private sector. So public-private is really happening now, just the conversations. And I think, the fact that we're plugged into, a community, the diasporan plus the local community of healthcare workers who, have not had it easy, but keep doing what they do every day.
I love that. Mrs. Laoye, thank you so much for sharing your wisdom, your vision. I mean, what is clear to me right now is that investing in healthcare in Africa is not impossible. It's happening. It's already unfolding. And I think now we just have to scale it and we just have to keep pushing. For all of our listeners, I encourage you to learn more about Iwosan Investments on LinkedIn or at iwosanhealth.com. And please don't forget to subscribe to The Cure and share this episode with anyone who is passionate about transforming healthcare in Africa. Any final words, Mrs. Laoye?
Just to say thank you, Temitope. You keep doing what you're doing.
Thank you so much. Thank you. See you in the next episode. Bye.